Aortic stenosis is a tight valve that creates a lot of stress on the heart and can lead to various complications, including people passing out, developing congestive heart failure, developing chest pain, and just not being able to thrive. Traditionally, when we replace the aortic valve, it always involves open heart surgery, where the chest is cracked open by the surgeon, and the bad valve is removed and a new valve is put in. Not everybody is a good candidate for open heart surgery because it is a major operation with potential risks, including mortality, meaning dying from the procedure or having a stroke, kidney failure, etc. An alternative to this approach is TAVR, where we go through a tube that is typically put in the groin artery, and we take a valve that is crimped on a balloon and take it through this tube in the groin artery, take it over a wire, and once it's in the patient's aortic valve position, we stretch it open. So it essentially takes the place of the patient's old valve. Most of these patients, we do not put them on the breathing machine. We just give them sedation and do the procedure. And most of them are awake within a few minutes after the procedure. And most patients get out of bed within 4 to 5 hours after the procedure and are walking. And in our experience, we send most of them home the very next day.
I was having problems with congestive heart failure, shortness of breath, couldn't do a whole lot, was out of breath walking up the stairs from the basement to the living room. I was in bad enough shape that I needed something to be done.
George did have congestive heart failure. He did have the typical symptoms of severe aortic valve stenosis, and based on a number of clinical factors, we felt that he would be at high risk for complications, including mortality and morbidity from open heart surgery. So he was felt to be an ideal candidate for transcatheter